Okay, it's about 12 o'clock and we'll go ahead and get started. This will be kind of a little bit abbreviated version compared to the one I gave a couple of weeks ago. But a couple of things. Most important right off the bat and to spread around is the four of us gastroenterologists would love to get your calls. If you have questions on what to do for a patient or how to take care of a patient, please call us. A lot of times I think it's kind of reflexive to just send a consult. That's going to probably go away, as we talked about, that's going to be going away in about a year's time. So truly, when you see a patient, you're not sure exactly what to do, you ought to consider calling us. That said, for myself, Tom Johnson, and Jeremy Fields, we all want to be called directly on our cell phones. Just give us a quick call. Don't call our office and be put on hold. Just call us directly. Larry Johnston, he would rather be paged. So call any of us, and if you have questions of all this. As I mentioned in the email, and we mentioned at the last lecture, in about a year's time, the GI department will stop all consults having to do with anything functional. Basically, that means anything that's not a colon cancer, inflammatory bowel disease, or end-stage liver disease. We probably will refuse the consult. Similarly, if you say, well, they've got abdominal pain, let's send them for a colonoscopy, we'll probably refuse the colonoscopy also. So it's going to be very important to learn how to take care of these patients since we won't be there to help you. So for the next year, we are here to help you. So you ought to start giving this a try, and if you run into problems, you can send them to us as consults, but it's time to start learning how to do it. A year from now, Tom Johnson and I will be here for a few more months until spring of 2025. Then at least there'll be four of us that we can still make phone calls to. Once TJ and I leave, then Larry and Jeremy are going to be drowning, and I don't know how easy it's going to be able to get a hold of them at all. So anyway, we're glad that you guys are here and want to kind of go through things. I'm going to cover several different topics. These are all things that we want you to be able to take care of completely. Like I said, if you have questions, call us. We can help you with it. But we want to get you into the feel that you don't have to send these patients for consults because, as I said, in a year's time, you won't be able to. We'll spend a lot of time on abdominal pain. That seems to be the hardest one. Then we're going to cover diarrhea, constipation, nausea, some other things too. So let me kind of talk about, switch right in, and we'll talk about abdominal pain. And I'm just going to streamline this. Hopefully all of you have this outline called the GI bare bones. It's something I wrote up a long time ago. In a sense, these are such common problems, I would recommend memorizing it. And that sounds a little strange, but you see this all the time. You should know in the top of your head how to treat these very common disorders. So I would look it over, follow the algorithms, see what works, if it works for you, and have them memorized. So that said, abdominal pain. As you know, we divide abdominal pain or any type of pain in the body into two types, organic and functional. Organic, as we know, is pain due to disease. That's what nobody has. Everybody has the other type of pain. That's functional pain. But without any disease whatsoever. And that's very, very common, whether it's a headache, chest pain, abdominal pain, limb pain. Most people with pain will have functional pain. Now, the problem is, if it's functional pain, you have to sell the diagnosis, and that's just the way it is. When I went to medical school and residency and fellowship, I never thought I'd have to be a salesperson, but if you want to succeed in treating your patient effectively and having them feel good about the diagnosis and so forth, you have to sell it. And that's what I want to go through with you is how to sell it. It has to be done there's a very precise way to do this, and if you deviate from this, the sales job falls apart, the patient thinks you don't know what you're doing, and they want a consult, which you will not be able to give them. So listen attentively to what I have to say. When you first see the patient, we get a history, and if they came in, abdominal pain is the chief complaint, then it's time, first thing we do is get a history. Prior to that, with anybody with abdominal pain, highly recommend look on the computer, spend a couple minutes to see what tests have been done. Because we're going to want to get two tests if they haven't been done. One is an abdominal pelvic CT scan. That rules out all of the organic diseases, and maybe a CBC also. Check and see if they've already had that. That will enter into your discussion with the patient if they've already had those tests. If they haven't had the tests, you will discuss it slightly different with them, and I will go through this here in a moment. So we've gone in to see the patient. They have abdominal pain. You've checked the computer, and let's just take the case where they've not had any of these tests. There's three things we have to have the patient feel good about. One, the patient has to feel good or feel well that you have listened to them and have heard everything they have to say. This doesn't take a long period of time, but it takes a little bit of time. The total time, my experience has been, is about 25 minutes to do the entire thing. Listen to the story and explain it and decide on treatment. It's about 25 minutes. It really doesn't take an hour or 45 minutes, but similarly, you cannot do it in 10 or 15 minutes. It has to be about 25 minutes. If you schedule the patient for a 15-minute slot, just tough. You're going to have to go long and give the time, because if you do it less than that, it won't be effective. So, like I said, we're going to listen to the patient's story. We want the patient to feel very good that you have listened and understood what they said. Two more things. You must acknowledge to the patient that you understand they have pain. The pain is real, and maybe it's really severe. And third, that you must acknowledge that the pain is in their abdomen. It's not in their head. They're not making it up, that sort of thing. And here's how we do that. So we listen to the whole story. Once we hear the story, and a lot of the story really doesn't matter to us, but it does matter that the patients have been able to tell you the story. Once we've heard the story, we can divide all functional abdominal pain into two categories: irritable bowel syndrome or functional abdominal pain. And the nice thing about dividing them into these two categories is that we can give reasons for the pain, different reasons for each of those two categories. And it doesn't really matter where the pain is. If it's up high, that can still be irritable bowel. If it's down low, that can be functional. It doesn't really matter. What makes the determination is whether they have diarrhea or constipation with their abdominal pain. If they do, it's irritable bowel syndrome. If they don't, it's functional abdominal pain. You just divide it simply like that. One more thing we want to know before we go into our explanation is, and this is critical, and I want to emphasize this, we must check for depression. Every person with pain, whether it's chest pain or abdominal pain, must be checked for depression. If they have depression, then treating the depression becomes critical. You won't be able to fix the abdominal pain until you treat the depression. It's irrelevant whether or not they're currently on medicines for depression or not. The question is, are they having depression, whether they are ostensibly being treated for it or not? I use three quick questions. One, do you feel sad or blue? Two, do you feel like crying over things? Three, anhedonia, do you have lack of pleasure? If the answer is yes to any of those, it's depression and we need to treat that. I'll still go through and talk about functional abdominal pain or irritable bowel syndrome, but I'll explain to them that our treatments will not work until we get the depression under control. We must get the depression under control, and that's what we put all the effort into. As an aside, I should say, of all the thousands of patients who've come my way over the years with abdominal pain, probably about a third of the time I find depression that was missed by primary care. Don't miss it. That's a key point. Everybody screen for depression. Nobody has abdominal pain until they've been ruled out for having depression. Okay, so we've talked to the patient, or the patient's talked to us. We've asked a few questions. Do you have diarrhea or not? If they do have diarrhea or constipation, I often will ask if they have bloating, because they usually do. And this is all going to help us in our sales job. We've asked for depression. No, they don't have depression, let's say. So at this point, I have not yet examined the patient. We haven't done a lab exam, but it's time to give them the diagnosis. And I'd like to explain how to do this, and I want you to kind of listen to this, because this is what works. And it's kind of like a stand-up comedian. They give show after show over the months and years, and they kind of hone their delivery to see what works. Having done this forever, I've kind of honed my delivery, and I found this works extremely well. So I'm going to give two examples. I'm going to give an example of how do we discuss irritable bowel syndrome, and then I'll give an example on how do we discuss functional abdominal pain. So, pretending I'm talking to the patient, and I'll break away to tell you what I'm doing here and there. Let me kind of go through it. We finished talking to the patient, and I'll tell the patient, that's very good. Let me tell you, I think I know what's going on. Now, this assumes they've not had their workup, their CAT scan and CBC. If they've had their CAT scan and CBC, I will tell them, this is what you do have. Let me tell you how I know. But we'll assume they haven't done that yet. We'll say, well, that's very good. Let me tell you what I'm pretty sure you have. This sounds very much like irritable bowel syndrome. If I could, and this is talking to the patient, let me tell you all about irritable bowel syndrome. Let me tell you what it is, why I'm pretty sure you have it, what it means to have it, and what we're going to do about it. Right off the bat, I tell folks, irritable bowel is a problem with the colon. So again, this is helping the patient. It's not in your head. There's a problem with the colon. Specifically, it's a problem with the peristalsis of the colon, again, talking to the patient. Now, what I mean by that is that the movements of the colon get all messed up, and let me explain that. The colon is this long, hollow tube, and attached to it at one end is the small intestine, and it dumps all of these waste contents into the colon. Now, if the patient's had diarrhea, I will go on with this part. So those waste contents start off very watery and slushy. As they get pushed along in the colon, that excess water gets reabsorbed back into the body, which is why we have a colon. If everything's working properly, what starts off as a slush at one end should end up as a normal bowel movement by the time it comes out of the other end. If they don't have diarrhea, there's no point in saying all that. But if they have diarrhea, that's going to help. It's explaining their symptoms. So now, to push those contents around, the colon is full of lots of muscles and millions upon millions of little nerves. These muscles and nerves do the pushing, and it's called peristalsis. It's like squeezing a tube of toothpaste. Your colon, if it's behaving itself, is supposed to slowly, gently squeeze things along. Peristalsis. If that slow, gentle peristalsis goes awry, you get irritable bowel syndrome. Instead of gently peristalsing, it can spasm. And when it does that, it hurts. And it can be anywhere in the abdomen. Well, some areas spasm, assuming they've had bloating, most people do. Well, some areas have spasm. Other areas will dilate up, and that's what causes bloating. And assuming they have diarrhea, I'll say if you peristalse too quickly, there's not time to absorb that fluid, you will get diarrhea. Or if they have constipation, I'll say if you spasm down, stool can't get through, and you'll get constipation. Some people have both, and then I'll mention all of that. Then I go on to say, to meet the Rome 4 criteria for irritable bowel syndrome, and I'm going to just list their symptoms to show that they meet Rome 4. You should have abdominal pain or discomfort, plus bloating, assuming they have it, plus diarrhea, or if they have both, plus diarrhea and constipation, which is very classic. Then I say, you meet all of the criteria for irritable bowel syndrome. Now, then I say, but that doesn't prove that you have irritable bowel syndrome. It makes it very likely, but to prove it, we need to know one more thing. That's that irritable bowel syndrome, even though it's painful, icky, terrible, it does not damage the body. And because there's no damage to the body, that means two things. One, assuming they've had it for a little while, you can have this for a long time and stay healthy. Now, if they haven't had it for a while, just for a month or so, I'd skip that part. Again, this is all sales job. You're selling this. Number two, it also means, and this is very important, this is very critical, it also means that any medical tests we do will be normal, whether it's an x-ray or a CAT scan, blood work, an endoscopy, all tests will be normal. Because when we do medical tests, we can't see pain and suffering. Again, that tells them that we understand they're having pain and suffering. We can't see pain and suffering, we can only see damage, and there's no damage from irritable bowel syndrome. So to actually make the diagnosis of irritable bowel syndrome, talking to the patient, we need to have those classic symptoms, which you have, and a negative workup. Now, if they've had the negative workup, I say, which you've had. So this proves that you have irritable bowel syndrome. If they haven't had the workup, I say, so what we're going to do is get a couple of tests. But this is critical. This is critical. I tell the patients, and you must tell the patients too, I fully expect these tests to be normal. If you go even the slightest hint that, well, let's get this test to check for some disease, you're screwed, and the patient will not like you anymore, because that test is going to come back normal, as it usually does, and the patient will think you don't know what you're doing. Well, the provider thought it was this, but they were wrong. Now they don't know what it is. That's the trap you fall into. Do not fall into that trap. Rather, say, we're going to get a couple of tests. We're going to get a CAT scan and a little bit of blood work. I fully expect these tests to be normal. Then I tell them, we'll order them, and when they come back, if they're normal, I'm going to have my nurse Eileen give you a call. But if they're abnormal, which I think is not likely, but if they are, I will give you a call. And then I tell them, I'm pretty sure it'll be Eileen giving you a call, and it almost always is. One quick thing. Well, gee, what if you find something on the CAT scan, a cancer or something? Will your patient be mad at you because you said it was irritable bowel? No. Again, having done this forever, that happens once in a great while. Patients are grateful. You found it. You're the one who ordered the test. They're not mad at you in the least. They're happy you found it. Well, they're not happy to find about a cancer, but there's no issue there. So you set this up, telling them from the get-go that this is functional, or this irritable bowel syndrome in this case. We're going to get a couple of tests and make sure, but I expect it to be normal, and this is going to be irritable bowel. At this point, I still haven't even done a physical exam, but now we're going to go on. I'm going to say, if I could, let me tell you, at this point, actually, you covered a lot. I say, now, I'm going to talk about how we treat this, but before we do you have any questions about this? We've covered a lot of information. Do you have any questions? And that's always good to answer questions. Next, then I go right into talking about how to treat it. Quick note, if you've done this successfully, if you've listened to them, they feel good that you've listened to them, you've acknowledged that the pain is real, you've given a reason for it, bowel spasm. My experience has been about half the times the patients no longer even want treatment. That's all they needed. They needed to have it explained. And I get a lot of really nice positive vibes. Patients tell me, oh, thank goodness, finally somebody could explain to me what's going on. If you do this correctly, the patients will really like this, and they'll really like you for having done this. Oh well, let's go on and say we do want to treat. What I tell patients, and I would recommend doing this, is I say there are different ways to treat, and what I'd like to do is let me just put them all on the table for you, and you can decide what you want to do. You can decide we can start something now, or you can think about it too. A lot of times they'll want to hear about it and then think about it, and maybe they'll call to treat, maybe not. I tell people there are three main ways to treat. The classic way is with medicines, and the classic medicines are tricyclics. Now, you have to tell the patients these are tricyclic antidepressants, so they don't, because they may read about it and then think you're trying to pull something on them. So just right off the bat, I tell them these are actually called tricyclic antidepressants. However, the dose that we use is too low to treat depression, which is true. So I tell them the joke is if we put you on this and for some reason you get sad, it won't help you, even though it's an antidepressant. It only works for pain, when that's true. Which medicines to use? Use nortriptyline or desipramine. Do not use amitriptyline. It floors me in this day and age that anybody would ever use amitriptyline. It works no better than nortriptyline or desipramine, and it has horrible side effects that nortriptyline and desipramine do not have. So if you want to give your patients side effects, give them amitriptyline. If you don't want to give them side effects, give them nortriptyline. The dose is 10 to 25 milligrams a day. Elderly people maybe start at 10. Younger people start at 25. Rarely you might have to go up to 50. If 50 is not working, then it's not going to work. And the success rate is about 80%. All right, let me tell you about the second way to treat. And this one you really have to sell. But this is very effective, and you should all know how to have this available to you. A second way to treat is hypnosis or cognitive behavioral therapy. Now, of course, as soon as you say that, what is your patient thinking? They're thinking, aha, they do think it's all in my mind. So we're going to tackle that problem head on. I say it's hypnosis or cognitive behavioral therapy. Not because the pain is in your head. It is talking to the patient. Not because the pain is in your head. It's not. The pain is truly in your abdomen. However, remember those millions of little nerves that we talked about. Those nerves communicate with the brain subconsciously. Our brain communicates with those nerves subconsciously all day long. It's crosstalk. And it's completely unconscious. We're not aware of it. What hypnosis or cognitive behavioral therapy does is it entrains the subconscious to send signals down to those nerves and get them to turn off. And remarkably, it's very effective. It's about an 80% cure rate. This would entail meeting with a hypnotist or cognitive behavioral therapist. It's usually about one session a week for about 5 or 6 sessions. And like I said, the cure rate's about 80%. You should all have in your armamentarium a list of your psychologists and counselors who do this. If not, we have a list for you, and just call our office. We'll get it for you, or we've got it up there. And what I found is maybe 1 out of 4 people are interested in that. The people who are interested in that, universally, it works extremely well. They want to try it, and they have really good results. Never force that on anybody. But I just laid it out, so that's the second option. Many people can't do it, even if they wanted to, because they don't have time to do it. They work and so forth. But people who do it get very, very good results. Third way to treat, and I tell people, and that is diet therapy. Unlike the other 2 ways to treat, diet therapy does not work very well. It maybe works about 40% of the time, and there's only a single type of diet that's ever been shown to work. And I tell people about this. The other types of diets, irritable bowel has been around a long time, so other diets such as a FODMAP-free diet, such as a gluten-free diet, dairy-free, does not work. It will not help your irritable bowel. And indeed, treating irritable bowel with diet, unless you use this FODMAP-free diet, is useless. It doesn't work. So I go on and tell people there's a single diet, came out of Australia, that's where FODMAP came from, called a FODMAP-free diet. It's very hard to do. You kind of have to Google it, and you'll get lists of foods you can eat, lists of foods you can't eat. It's very difficult to follow. But if you want to try it, you can. It doesn't work for everybody, but sometimes it works, and it's kind of hard to do. But if you wish, that's a third way to treat. Then I go on to tell them, but if you're not going to do the FODMAP-free diet, personally I wouldn't, but if you're not going to, eat whatever you want, it makes no difference. You will not fix your irritable bowel, this abdominal pain, by changing your diet. It just doesn't work. And that's been experienced over years. So to sum up, talking to the patient, we have medicines, these tricyclics, or that funky hypnosis, cognitive behavioral therapy, or if you wish, we can try the FODMAP-free diet. Like I said, we can do something now, or you can think about it and call me if you decide you want to start one of these. And that's the story. We do that, and like I said, about half of patients don't even want treatment, and about half do. And they're very grateful. You've explained it to them. They've got a reason for their pain. You've recognized that the pain is real, and you haven't shot yourself in the foot by saying, I think it might be your gallbladder, or I think it might be acid reflux, or it might be diverticulitis, because it's probably not. Now, a couple of little caveats. What if the patient comes in just with classic heartburn? I would still mention there's a good chance it's functional, because most heartburn is, but this could be acid reflux. We can tell that simply by starting a PPI. Quick thing about PPIs. Pantoprazole is the weakest of all of them. It sort of works okay, but it's not very strong. I don't know why anybody would use it. It's kind of like using Losec to treat everybody's cholesterol. It's the weakest of all of them. It's one-fourth the strength of Prilosec. 40 milligrams of Protonix is equal to about 6 milligrams of Prilosec, is equal to about 3 milligrams of Nexium. So I would start somebody, if you're going to start a PPI, use Prilosec, use Nexium, use Prevacid. You can use Protonix if you want, but patients come to my office, I'm switching them off of it all the time. It's just not a very good drug. There had been thought 15 years ago that Prilosec might hurt clopidogrel, that's Plavix, but it doesn't, so it's safe to use. You're right, that's just a thought. But anyway, if heartburn, say, well, try this. If it works, great. But if not, that's going to show it's probably functional. You've got to kind of say that. One more caveat, and this is all in the bare bones, just, kind of read through this. In our history, if we find that the pain radiates around to the back, and particularly if it's positional, that's probably musculoskeletal. It's not functional, and we treat it as musculoskeletal. And that's outlined how to do that in the bare bones. So that's how we would approach this if it was diarrhea, constipation plus abdominal pain. Let's very briefly take the patient with abdominal pain but no change in bowel habits. Okay. I tell the patients, what you have is functional abdominal pain. Again, talking to the patients. Let me explain that. This is how I explain this. Our body is full of millions of pain nerves from our tip of our head to the tip of our toe. And those pain nerves, they turn on, cause pain. I say, I use this example. For example, not that we'd do this, but if we took a hammer and smashed you on the toe and blindfolded you, as soon as we smashed your toe, you'd say, ow, your toe hurts. Well, that's because nerves sitting right now in your toe would suddenly turn on and send pain signals up to the brain. If instead of using a hammer, we could just magically get those pain nerves to turn on, you would have exactly the same pain. That's what's happening with this functional abdominal pain. We don't know why, but it's very common for these abdominal pain nerves to turn on when they're not supposed to. They just do, and it causes this pain. That's what's going on. Now, to make sure that that's what's going on, we're not missing anything, we are going to get a couple of tests. We're going to get a CAT scan and some blood work. But again, I fully expect these tests to be normal. And if they are normal, by definition, this is functional abdominal pain, and that's what this is going to be, I'm pretty sure. Again, if you get a CAT scan and you find Crohn's disease or something, you found it, they won't be mad at you. Do this, approach it this way. The treatment is either tricyclics or hypnosis behavioral therapy. Skip the diet. That's not going to help in the least for functional abdominal pain. So it's similar, but you've given them, once again, a reason for the pain nerves, which we all have turning on, and we're going to work to turn them off, either with the tricyclics, and I explained, by the way, that tricyclics work on those nerves to turn them off, or hypnosis behavioral therapy. And that's kind of the keys for abdominal pain. There's a couple of really key take-home points. Number one, check everybody for depression. If they have depression, I might go through that whole thing, including how we treat it, but I will say, but we're not going to do any of this treatment because it won't work. We've got to bring your depression under better control. And you have options for depression. You can place on medicines or increase doses of medicines or add additional medicines, or you can send for behavioral therapy, or you can send to psychiatry, but you got to do something. If they have depression, yes, I do feel sad. No, I don't really enjoy anything. You must treat that. When you treat that, there's a very good chance the abdominal pain will go away. If it doesn't, these other treatments will work great, but often it just goes away anyways. Don't miss the diagnosis. It has to. have to clear everybody whether or not they have depression. Check for anxiety too. That doesn't tend to cause pain as much, but that's easy to check. Just ask if people are overly anxious. So that's the first point. The second point is once you sell this, once you hear the story, do not say, well, I'm not sure. This could be gallbladder. This could be this. Don't do that. You've ruined it if you do that. Be definite. This is functional pain. This is irritable bowel syndrome, or this is functional abdominal pain. You'll find out once you get the rest of the tests. And if you're off, no harm done, because there's their liver their cancer or whatever, and they're going to go off to oncology, and you've done your due diligence. But if those tests are normal, it is functional pain, and you don't want to shoot yourself in the foot by saying it could be anything else. You've got to hit the functional pain first. That's what you got to do. I'm going to move on to other things. Like I said, we all have phone numbers. If you have any questions about this, call me or my colleagues anytime. I'd be happy to discuss it in more detail, or any specific cases, happy to talk it over with you. That said, I'm going to kind of work our way through the bare bones just a little bit, just to kind of cover a couple of things. Again, if you don't have a copy of it, just call my nurse Eileen, 894333, and we'll just get it to you. So a couple of thoughts. Let me, if I could, let me segue to nausea, because that's another very common problem. That also is usually a functional disease, and is treated the same way. Nausea, and this is all in the bare bones. You just go through a simple process. The first thing I would check nowadays, particularly, is if they recently started any diabetic medicines. Virtually all of the diabetic medicines, from metformin all the way to seraluglutide, all of them can cause nausea. Insulin doesn't, but all the other ones do. Have they started that? If so, give a trial of stopping the medicine. I can't tell you how many times people have been sent to me for nausea, and we find out, oh, they just started metformin, or they just started seraglutide. We have them stop it, and the nausea goes away. You guys should, you guys are the ones prescribing that. Check for that, and check and see. If so, that's your first step: is stop it for a short while, see if the nausea goes away. Number two, marijuana use, very, very common. I always ask, and I try to put this as nice as I can. I tell patients, I really don't care in the least, because I don't, but by any chance, do you use marijuana? And sometimes patients will say yes, and then you're done. That's the problem. We'll talk about what we tell them. But sometimes they'll say no. If they say no, I say, great. Just to let you know, as part of the workup, and I just tell them this, we are required to do a drug screen. That's just what we have to do on everybody. I do this on 80-year-old women who come to see me with nausea, which I actually do. So everybody gets a drug screen. And what I found is interesting, when I will tell them a little bit more about marijuana anyways, and about a third to half of the time, we send people down for their drug screen, and they never get the drug screen, and they never come back, probably because they use marijuana. So it's probably good to explain to them a little bit about marijuana. This is what I tell them. No harm from it, but about a third, maybe 25% of people who use marijuana will get nausea at some point in their use. It may be years after beginning. They may have been on it for years, and now the nausea hits, or it may be a little sooner. And once it occurs, they'll have that nausea no matter what you do until the marijuana gets out of their system, which takes 6 weeks. I don't know if you're aware of this. If you use marijuana and you do a drug screen, 5 weeks later, we'll pick it up. It takes 6 weeks to clear THC out of the blood and out of the urine. So, and I tell patients this, it takes 6 weeks. And I say, what our first step, since you do use marijuana, or if people use marijuana, is we must get the marijuana out of the system. And if you still have nausea, then we'll treat. And if people don't do a drug screen, and they come back to see me, which really hardly ever happens, I'll say, well, we can't do anything about it till we get that drug screen. And if the drug screen is still positive, then you have to wait till the marijuana gets out of the use. I've had some patients, maybe you have too, who have a positive screen and just can't believe it's positive because they don't use marijuana, but tough. I tell them, yeah, I guess not, but somewhere it somehow get into your body, and you got to get it out of your body. So check one for diabetic medicines, 2 for marijuana. That'll cover a large percentage of your chronic nausea cases. Number 3, depression. All of these, check for depression. If they have depression, if you treat the depression, the nausea will go away. We catch that quite a bit. Okay. Well, we've checked. They're not on diabetic medicines, or if they are, they've been on it for years. And diabetic medicine will usually start causing it fairly soon. You screen them for marijuana use. They're not on marijuana, and you've done the screen, or you're going to get the screen. Now it's chronic nausea. Now, and you've checked for depression. They don't have depression. So, and there's no other obvious things. They're not getting chemotherapy. They didn't just get off the ride at the amusement park. That sort of thing is chronic nausea. Here's how we explain that. What I tell people, and this is very effective, is all nausea comes from a small part of the brain in the brainstem called the chemotrigger zone. And the chemotrigger zone is full of these little nerves. If those nerves turn on, you will get nausea. If they turn on stronger, you will have nausea and vomiting. If they turn off, you will not have nausea. All nausea comes from that one little area of the brain. I tell them certain things can set it off. For example, for people who get chemotherapy, the chemotherapy goes to that chemotrigger zone, turns it on, they get nausea. If you're like me and you go on a carnival ride, that'll screw up your vestibular system, that'll turn on those nerves. But I said for many people, such as you, those nerves turn on for no reason. This is similar to functional pain. We don't know why they turn on, they just do. And our job is to turn them off. What we've learned is that the typical anti-nausea medicines do not work well. Zofran does not work well, Phenergan, Compazine, none of that works very well. What works really well is two things, tricyclics and cognitive behavioral therapy or hypnosis. That works for chronic nausea. So we go through the spiel again. Again, if you're going to use a tricyclic, tell them that it's an antidepressant, but the dose is too low. It will not treat depression because we use the same dose, 10 to 25 milligrams. Number two, in addition to that, to the tricyclic, remember to tell them that it takes time to work. It takes about a month before it really starts kicking in. So that's important that they know that, so they don't quit after 3 days or something like that. And we just kind of go through that and explain to them that it's not anything dangerous or harmful, but it's annoying, nobody likes it, it's uncomfortable, and that's how we treat it. So that's the nausea workup. It's very 1, 2, 3. Diabetic medicines, yes or no. Marijuana, yes or no. Screen for it. And then depression, yes or no. None of that. Explain it. It's just the chemotrigger zone turning on for no reason, and we'll stop it with tricyclics, which work really quite well. Sometimes with the tricyclics for nausea, you have to go up on the dose, sometimes to 50 or even 75 milligrams. Unlike abdominal pain, usually it's a lower dose. So that's how you treat nausea. Again, just kind of coming through this, a few things to say about constipation and diarrhea. Constipation, let me back up one step. I was about to say, constipation is not ever a reason to order a colonoscopy. It's just not. Nor is abdominal pain. A colonoscopy or an upper endoscopy does not help us with abdominal pain. We get a lot of open access patients sent to us for colonoscopy for constipation, and it's a dumb reason to do a colonoscopy. It doesn't help you. And same with abdominal pain. The CAT scan is what helps you, not a colonoscopy. Constipation, a couple of things to tell your patients. One, yes, it's annoying and bothersome. We're going to talk about it. However, it is never a sign of disease, nor is it ever harmful. And a lot of patients are worried. Gee, doc, I poop once every 2 weeks. Am I going to die? No, you can go 3 weeks between bowel movements forever and ever, and it will not harm you. It might be really uncomfortable, but there's no harm from it. The way to work up constipation, and again, this is all in the bare bones, is one, you can just empirically try laxatives if you wish. The best way to use laxatives is to make sure you take them every single day. That works best. But if the patients are really bothered by it and they want to work up, the two tests you get are a SITS marker study, and you guys, we have them in our office, but you'll have to get them for yourself because they cost $60 each. So you can call my nurse Eileen, and she'll tell you where you can buy them. 894-333. A SITS marker is simply a capsule. I don't know why they're $60 or whatever they cost. It's just a capsule with 24 little plastic O-rings in it. You swallow it. 5 days later, you take an X-ray and you see where those O-rings are. Again, this is all outlined in this. This is the test you want to get. The second test is to send people to Katie Albrecht, and you should all know Katie Albrecht. She's a physical therapist here at Mary Greeley. She's a defecatory disorder expert, and she will do a balloon expulsion test to see if they have what's called pelvic floor dyssynergia. Again, this is all outlined. Those are the two tests to get. If the patient has that, and it's very common, Katie will then treat it. You're taken care of. She's going to take care of it for you. Diarrhea. I'm going kind of quick. This is all in that outline, which I urge you to look at and memorize. Diarrhea. Break it into two parts, acute and chronic. If it's 6 weeks or less, it's acute, and it's probably due to an infection, usually a viral infection. Longer than 6 weeks, it's chronic, and it's not due to an infection. Common mistake. People have had diarrhea for 3 months and everybody gets stool studies on them. That's dumb. You will not catch anything on it ever. Don't bother with that. The test of choice, if you want to test for chronic diarrhea, is a 48-hour fecal fat study. Some people sometimes get a 24-hour fecal fat study. That's useless. We've tried to get it eliminated from the lab. We've not been able to do that. Just don't order it. It needs to be 48 hours to have any, to be able to tell anything from it. And again, it's all outlined how you interpret that and what you do for that. So I'm just kind of hitting some of the common errors that people make. For acute diarrhea, it's often a viral infection, and often nothing works. I mean, people are miserable. They go on high-dose Imodium, they go on Cholested, everything, nothing works. And then after 4 or 5 or 6 weeks, it simply stops. That's very, very common. If it goes on more than 6 weeks, then it's time to consider doing a workup. The workup, the test of choice, is not a colonoscopy. Don't send them for a colonoscopy. Do the 48-hour fecal fat study. It's a simple lab test. They do it downstairs. They go to the lab, pick up the bucket, and they collect stool for 2 days. It gets shipped up to Mayo Clinic, and it takes about a week to get it back. I tell patients that. When it comes back, go ahead and start ordering these. And if you have any questions on how to interpret them, call us, and we'll go through it with you. It's very easy and straightforward, and it's outlined for you. But if you have any questions, ought to be doing that. So bottom line for diarrhea, no colonoscopies. If it's acute, do get a stool study. It'll probably be negative, but if it's not acute, if it's gone more than 6 weeks, don't get a stool study. Go ahead and get a 48-hour fecal fat study. Oh, one more thing. So acute, and the people get messed up on this all the time, and it's because of the way it's written. We have now, if you want to look for C. diff, there's a test called a C. diff complete, and this really kind of throws people for a loop. The C. diff complete will give you kind of 2 data points. One is whether the C. diff is there. And if it is, it'll say positive in big, bold red letters with that positive, and you'll think, aha, they've got C. diff. No, that just means the bug is there. It doesn't tell you whether they're a carrier or actually have diarrhea from the C. diff. For that, you need the second data point, which is just below it, is the toxin present. And this is protein toxin, toxin A and toxin B. If that's positive, yes, their diarrhea is due to C. diff. But if it's not, if it's negative, their diarrhea is not due to C. diff. They're a carrier, as almost every elderly person is a carrier. So don't be confused by that. If you have any questions, call us before you start the patient on vancomycin. It has to have the toxin positive. You might look at that lab if you ever order it. If it says C. diff is present, that's not good. Even though it says positive, that's not good enough. It has to be the toxin that's positive. Again, questions or anything, call us on this. But people seem to get confused on that. Discovering a couple of other quick things. Chest pain, vast majority of cases of chest pain are going to be functional because everything is functional. Obviously, you have to rule out cardiac disease. And then we see patients a lot for this. I think a simple trial of a proton pump inhibitor, not Protonix, not good enough. Use Prilosec or Prevacid or Acefex for about 2 weeks or so. If that gets rid of all the burning pain in the chest, great, but it probably won't. And if it doesn't, then this is almost certainly functional. An upper endoscopy will not help you. Maybe if we really think that they just don't respond to PPIs, we could do a 48-hour pH study. But if we're just going to do a regular upper endoscopy, it's not very helpful. Don't send your patients for that. It's a waste of their time and money and so on. How do we treat chest pain? If it's not cardiac and it doesn't respond to a PPI, same way we treat everything functional. Tricyclics or hypnosis cognitive behavioral therapy. That's their armamentarium. And it works really well. It works for all of this. So I would urge you to kind of use that. Okay, I'm going to finish up here. Just a couple of little odds and ends and so on. A couple just where we see mistakes commonly made. Diverticulitis. Nobody has diverticulitis until you get a CAT scan that proves it. And we see this a lot. If a patient comes in your office, they're having pain and a little fever, you think this might be diverticulitis, do not start them on antibiotics unless and until you get a CAT scan that shows that it's diverticulitis. You're almost committing malpractice to do that. You must get a CAT scan. Furthermore, if you've proved diverticulitis 2 times, they've come in once, got a CAT scan, yes, there it is, diverticulitis, we'll start some antibiotics. And a few months later, they're back with the same thing. You repeat the CAT scan, you need to. Aha, there it is again. At that point, then it's going to be time for surgery. Not during the acute attack, but in between attacks, so they don't keep occurring, because it can get worse and worse. But you have to have proof, and clinical history doesn't work for diverticulitis, so you must have proof for the CAT scan. CAT scans are extremely helpful. Which brings me up to one more point as I kind of think about these things. All you need is one CAT scan. We see patients who go see their provider of their abdominal pain and they keep getting CAT scan after CAT scan after CAT scan. You don't need multiple CAT scans. A single one is all you need. And once you've had a single one and it's negative, you're golden. It's functional. You've proven it. There's a kind of question, how do you get CAT scans? Sometimes insurance companies aren't very good about it. You must get a CAT scan, especially for older patients. For myself, people are under age 30, I don't bother, but if you're unwilling to say it's functional without a CAT scan, get CAT scans on those people too. A couple of ways. One, if they ever go to the emergency room and say they have abdominal pain, they will get a CAT scan. So check and see. Maybe they've been to the emergency room. Maybe they've already gotten their CAT scan. Two, if you can ask them, have you ever lost any weight at all in the last 2 months? Did you lose even a pound that you may have regained? Okay, weight loss. You can get a CAT scan with that. And if that doesn't work, then I would, insurance companies, if they're going to deny a CAT scan, I would say, fine, to the patient, next time you have pain, please go to the emergency room. That way we'll get our CAT scan. And you can use that kind of as a technique. So everybody must have a CAT scan, but only one CAT scan. Don't get repetitive ones. As soon as you've had one, you're golden. You've got the answer because it's been normal. Obviously, if they had a CAT scan in the ER and it was a cancer, they wouldn't be seeing you for their abdominal pain. So check before the patient walks in, make absolutely certain that, check and see, go through the imaging. Can you find a CAT scan anywhere in the last year? If you find it, great. You don't have to do it. You can tell the patient now, I know for a fact this is functional abdominal pain. Here's why. I can tell you for a fact this is irritable bowel. Here's why. A couple of last things. Elevated liver enzymes do not require. We get a lot of consults for elevated liver enzymes, and we're not doing anything that anybody else could do. We just order labs. That's all it is. It's a lab sort of thing. You order labs and get the labs back. It's usually, you get an ultrasound in the labs. This is all outlined for you, and it's usually be fatty liver. This fatty liver you treat with vitamin E, 800 units a day. It's all outlined for you. We're not doing anything special. The reason I'm going through all this, again, is because we're going from 4 down to 2 gastroenterologists. We can't do all of this anymore. We've done it for years and been happy to do it, but we can't anymore. We're not going to be able to, so you guys have got to carry the ball. But it's all written out for you. And I think that's just about everything I'm going to cover. Oh, one more thing. One more thing. Diarrhea. When patients ask diarrhea, there's one more question you really want to ask. Are they having accidents, particularly your elderly patients? Oftentimes, it's really not a diarrhea. They're just too embarrassed to say that they're having accidents. So always ask them, because it's treatable. It's totally treatable. So when somebody has diarrhea, I always ask, let me ask, are you having any accidents where you can't make it to the toilet in time? And a lot of times they'll say, yeah, and it turns out that's really the problem. Great. There's a 2-step. This is outlined for you. You do not need a consult for this. You can do this. You do 2 things. One, start them on Metamucil. I like the wafers. I think they come as cookies. That's a lot more palatable than the powder, but whatever. And I tell the patient, if you take the Metamucil wafers every single day, about half the time those accidents will go away. And it is about 50% of people, they're cured by Metamucil wafers. So let's try that. It's easy to do. But if it doesn't work, you're in the 50% where it doesn't work, then you refer them to Katie Albrecht, and she does biofeedback, and she fixes the problem. So it's very fixable. It's very treatable. Ask your patients. Don't send them to us. Well, you used to, but you're not going to be able to. Treat it yourself. Just ask them, you're having those accidents. Let's start the Metamucil. Are you taking it by any chance? If they aren't, start them on it. If it doesn't work after 2 weeks, and give it 2 weeks, have them call you and just refer them right on to Katie Albrecht. Physical therapy at Mary Greeley. She's wonderful. Really, really excellent. She's been here for years. A fantastic resource that we all should be using. So I would urge you for that. A couple other quick things. We get this consult. People come in with a lump in their throat. That's called globus sensation. It's totally functional. There's nothing you can do about it. You do not need any workup at all. You don't need to do a CAT scan of the neck. You don't need an ENT exam. You do not need an endoscopy. If they say, I always have a lump there, it's just an annoying thing. It will go away in time, and you do nothing about it. You just explain it to them. Again, that's in the outline too. And I think with that, I'm going to probably bring this to a close. The most important thing I would say is to call us. Call us. Start working on these types of problems. You guys can do this. But if you have questions on how to do it, call us. Just call us directly on our cell phones. And we're friendly. We like to talk. We like to talk about cases. We're glad to help you out. So if you haven't gotten the handouts, ask for the handouts. We also have a list of all of of some of the providers who do hypnosis, cognitive behavioral therapy. We've got that handout if you'd like that. You probably have your own group, but if you don't, there are groups that you like to use. We have a group. We have ones that we found are very good for that. You'll notice there's something called rumination syndrome in there. You treat that with breathing exercises. We have the handout on that if you'd like that also. But mostly, call us. Don't send us consults. Call us instead. And appreciate everybody who signed in, a lot of people online here, and look forward to hearing from you. Thank you.